say we are living here in Singapore when it's really just a bunch of rocks on the water.
Yeah, exactly. It's a classification system, and it's had huge use as a classification system. You know, it's been really helpful for services organizing themselves and getting funding. Like I said, it's helped people decide on eligibility for services. So there's been some good things around it, but we kind of almost talked ourselves into a point of believing our own classification system rather than understanding that is what it is, just a classification system.
Humans really good at confusing themselves, are they?
Hi guys, thank you for tuning in to PsychMic. This show is an initiative by the student marketers of James Cook University, where the group of us, helpfully obsessed with psychology, attempt to bring in complex research into our daily lives.
In each episode, we dive into a psychological topic with a critical twist to see what gives. And without any further ado, let's dive right into it.
The views and opinions expressed in this podcast are those of the speakers involved and do not necessarily reflect the official policy or position of James Cook University Singapore or any of its affiliates. This content is provided for informational purposes only and should not be construed as definitive legal advice.
Well, hello everyone, and welcome to a new episode of PsychMic. Today I'm joined just with Joanna. Hey, nice having you on.
Hi, thank you for having me here.
Yeah, great. It's nice to be in this location that is very closely linked to the topic that we're going to be talking to today.
Yeah.
So yeah, just a little teaser. Actually, we're recording this whole thing in the psych clinic in James Cook University. We actually do have one. There's always space here for people who want to talk. And Joanna is also one of the people who is, doing sessions over here. So
I'm supervising sessions over here. So this clinic is staffed by the trainees on the Masters in Clinical Psychology program.
yeah.
And then as the lecturers on the program, we supervise them while they're in their placements.
Ah, I see. Yeah, because your main field is clinical psychology.
Yes.
Which I think to many people is sort of a term that has been going around. But I think there's still somewhat of an uncertainty going around it. So maybe just to delve into the conversation, can you tell me a little bit, what do you do as a clinical psychologist?
Sure. Okay. Maybe I'll start a little bit about the training. So clinical psychologists, they've done their undergraduate degree in psychology, and then they've gone on to do professional training in clinical psychology. So there's various professional psychologists, but this is the branch that focuses on assessing, supporting, and kind of treating people who have mental health problems, or psychological distress. So day to day, and previously before I joined JCU, I used to work in the National Health Service in the UK, and day to day it would look like meeting with patients, sometimes they're called clients, to assess them for what it is that's going on in their life that's causing them distress. And it could be doing understanding their personality structure, doing personality assessments, understanding how their brain works, understanding their level of, say, intellectual functioning or how their memory works, to really get a sense of what it is that is contributing to the problems that they're having. And then using that, we develop a formulation, which is a descriptive account of the type of problems and the explanation for the problems that the client's having. And from there, we do treatment. So you may have heard of things like CBT and ACT, yeah?
Right.
So yeah, like cognitive behavioral therapy or acceptance and commitment therapy. But there's lots and lots of different types of treatment that we can do to support people with whatever it is the problem they're having.
Yeah, I mean, that already gives away also where you're from.
Yes.
This is the whole European round today in a very different place. And yeah, the whole rundown, and it kind of shows, right, how detailed and implicit the whole thing is. Not implicit, but how detailed the whole structure of the diagnoses are that we're going to get into.
Yes.
So yeah, for the students in JCU, right, they're already in masters is basically the point where it gets more hands-on, where you move on from just studying about the theories and how therapy is to work in practice and getting to try your hands-on. do you also want to share a bit, like what kind of stories and experiences you have made with students in JSU and with that whole part of teaching?
Yes. So, I mean, like you said, like through the undergraduate bit, they've learnt all of the theory relevant. So pretty much here we're drawing a lot on abnormal psychology. I think as it's typically been called in the past, or like psychopathology might be another term. Undergraduates might also study like assessment processes as well, how to develop valid and reliable psychometric tests. So in the master's program, it's applying all of this. So we kind of walk them through various coursework subjects. We teach them how to use the tests that they've learned about developing. So how to use screening measures to understand if someone's, let's say, presenting with depression type symptoms or anxiety symptoms. As I mentioned before, sometimes it's screening their personality structure. There's tests of cognitive functioning or how their memory functions. Sometimes tests of executive functioning, which is like the frontal lobe of the brain. So people would have learned all about the kind of brain structures and the tests in undergraduate, but we're teaching them then how to apply these tests, how to administer them, how to score them, interpret them, and then write a report. Because you can't, a test just gives you really a set of data, it gives you a set of numbers, and you have to integrate that data with what you know about the client, like their background, their context, their upbringing experiences, their cultural context, other psychological processes as well. So it's kind of fitting together pieces of a reasonably complex jigsaw to coming to an understanding about someone's current level of psychological functioning.
Wow, yeah.
So,
that must be quite a big step, right? To like sort of the driver's seat of psychology.
No, I think it is. And it's very hands-on, that the students really like it because it's very hands-on in the classroom. It's very applied.
Definitely, yeah. Get to be a bit more practical. Is there like any kind of stories or experiences that have like stuck with you from these interactions? You don't have to name names.
Not off the top of my head, no.
All good. But then another thing you have mentioned, right, is the whole kind of assessment process, which involves the one thing that is really big in psychology, which is diagnoses, and something that we also want to talk a bit more deeply today. So first of all, can you kind of explain to our viewers who are might a bit less familiar with all that, how does that whole thing, so we have heard like the process, but like kind of what's behind the whole diagnostic iceberg?
Yes. Okay. I guess in how I've talked so far, I almost deliberately haven't used the word diagnosis. So, but a diagnosis, and people, it's fairly common language now, but people will understand that a diagnosis is about whether or not someone meets a certain list of criteria for what is then called a mental disorder. So there's obviously overlaps with medicine and kind of physical diagnoses. So for example, someone might end up with a diagnosis of diabetes, which means that their body is functioning in a certain way. And so that's fairly easy to check. There are tests that you can do within medicine to establish whether or not someone has diabetes. So diagnosis really came out around about probably the 1950s. So it was kind of post-Second World War. And at the time, there's a kind of manual that psychologists, but also psychiatrists use as well to diagnose, which is called the Diagnostical and Statistical Manual of Mental Health Disorders. I'm just going to use the term DSM because that's kind of a bit of a mouthful to say all the way through. And so the first edition of the DSM came out in around about the early 50s. And at the time, it was trying to find a way of helping professionals communicate more clearly with each other, a bit of like a common language, so to speak. But it was quite descriptive, it was quite based on psychoanalytic thinking, really. And it was really looking at the types of problems that people had in specific contexts, or maybe relationship problems, and ideas from psychodynamic thinking, like inner conflicts. But it wasn't a particularly kind of exhaustive list of all the disorders that you've now recognized today.
Indeed, yeah. The DSM is definitely a thing that has grown exponentially.
Yes.
With each sort version.
We're on
We're going to talk to that.
Yes, exactly.
Yeah, that's a whole discussion, I'll say, for a few minutes time. But so it, as you mentioned, it has been kind of this thing to standardize the whole process of it. And nowadays, what has kind of become, like, how do you view its use and function these days?
So a little bit more in the history. So then it's from that very early version of it, what people noticed, so there were these descriptions of different types of problems that people have, but it wasn't very reliable, which is a thing that psychologists are always very keen to establish, is the kind of reliability of diagnosis, which means if two different clinicians use that very first edition of the manual, the client could end up with two very different diagnoses. So that doesn't make it very reliable. So around the 60s and 70s, and then it came out in 1980, version 3 of the DSM was very much about establishing the reliability of diagnoses. So they got, rather than being descriptors, it kind of turned into checklists. And each disorder then had specific criteria that would describe that disorder. And then the manual guided people through to make kind of yes-no decisions.
Right.
So I don't know if an example would help here, say like depression. So some of the key criteria might be that someone's had a depressed mood, and there'll be a time frame associated with this. So that mood must have been depressed for at least 2 weeks. Say in the past month, and that you can kind of tick off that box. But they also might need to meet criteria for having like negative thinking patterns, or for having like a reduction in appetite, or for not being able to engage in their usual activities. So there's various different criteria that then a clinician kind of works through and makes a kind of yes-no decision. Does the client have this particular symptom? And in this, they meet then a certain number of symptoms, you can then give them that particular diagnosis. So in this case, depression.
Yeah, correct. You mentioned also the term symptoms, right, which is established as kind of another level of the whole thing. And then basically a diagnosis is being made up of a different set of symptoms for each one. And then you get the whole issue of having one symptom corresponding to potentially several diagnoses, and you have to kind of make up which constellation that's.
Yes. Yeah. I mean, the symptoms absolutely can cross over across different diagnoses. So, well, let's go back a step first. So, I mean, doing this made diagnoses more reliable. So if we go back to that idea of reliability, clinicians could use this third version of the manual and see the same client and be much more likely to come up with the same diagnosis.
Right. As it kind of made them understand better, like how they play together, so that don't falsely attribute one symptom sort of to the wrong diagnosis.
Yes, exactly. So it became much more discrete and distinct, was the idea that each disorder was supposed to be like this unique set of symptoms, and another disorder would be another unique set of symptoms. But it didn't really make it any more valid. So validity is the other idea that psychologists are also very concerned with. So is what you're measuring actually a real construct in the world? So whereas diagnoses became more reliable, they didn't necessarily become more valid. Like the DSM isn't a accurate description of nature, so to speak.
Yeah. As many, I mean, just a lot of things first have also disappeared. So this DSM just didn't like grew and kept everything in, like stuff like homosexuality, for example, right, which used to be in there, and now nobody would think of as such a thing.
Yeah.
There are still like ongoing debates, like ADHD, is that a thing? Or
yes, absolutely. That is in the DSM. That it's been changed. There's been various revisions. I think we're on DSM-5 now. So each disorder kind of usually has like a working group behind it. And then they're deciding really on what the key symptoms, but importantly also what the thresholds are. So again, it's not really that we're mapping onto reality, like whether or not something is a disorder is decided by a committee. It's not decided by a blood test or a brain scan or particular maybe scores on psychological tests.
Very technocratic.
Yes. Yes.
Could be unbiasing it for us something like that. So we've already seen that there are certain inches in the process of finding your sort of diagnosis and what's wrong with it. When we look towards the treatment sort of side, which is the other part of it that hopefully usually follows, where do you stand in that point, and how do you experience these things that we have mentioned so far?
So I guess as the DSM has become more prominent, it's used a lot more widely. It's been very widely adopted by the mental health system. So following like probably around DSM-3.
Yeah.
And so it's really become like the guiding framework for how mental health services are organized. So at a policy level, like a diagnosis really becomes a passport into the system. Like in order to be eligible for mental health services, you quite often need a diagnosis. Whether that's because it's kind of publicly funded or perhaps maybe it's through insurance. A clinician needs to give a diagnosis in order to make the client eligible for services. It has also become very prominent in, let's say, legal cases, within forensic cases in the court, for people getting educational accommodations. So you kind of mentioned ADHD, but there's also kind of specific learning disorders that would mean if someone had a diagnosis, they may be able to get accommodations for exams or for coursework or things like that. So it's become... Yes, like I say, it's become very prominent, its usage, and then it becomes how services are organized as well. So services are quite often streamed into diagnoses. So you have this clinic over here, which mostly sees depressed people, and this clinic over here, which is for anxiety disorders, and this one here that might be for personality disorder or psychosis and schizophrenia. And then... it's also been used to kind of guide research as well. And this then links to the treatment bit as well. So if you want to get funding to know whether a particular treatment works for a particular problem, then you normally need to tie that to a diagnosis. So you might say, I want to test out if acceptance and commitment therapy works for depression. And then you might apply for a grant, but then you need to find a whole group of depressed people. And then typically what you need to find is you need to find a whole group of depressed people to go through your research trial who also don't have any other psychological disorders, because you kind of want to test depression purely, not if it's mixed in with anxiety or maybe some substance use problems or maybe even some social problems as well. So then...
isolate that.
Yes, exactly. So then all of our treatment, our evidence-based treatment, comes out of these research trials, which have been based on these quite specific diagnoses. And on the one hand, that's been wonderful. Like, absolutely, we should be doing evidence-based treatment. I don't think there's any argument against that. We should be testing out which treatments work. But on the other hand, people don't really fit into these kind of neat diagnostic boxes. And as you kind of mentioned quite a few times, like the DSM has grown so much over the past, what are we going up to, like 40 years.
Yeah.
We've got so many more diagnoses that we used to have. And that's not because so many more like mental health disorders have suddenly appeared. It's because we're kind of splitting human distress into smaller and smaller boxes.
Yeah.
And
trying to make everyone fit
into a box. And people don't really fit in boxes. But the whole system is kind of feeding back into itself. Like I said, like clinicians often need to give a diagnosis to allow someone to be eligible for treatment.
Yeah.
So, personally as a clinician, I might say, I don't really believe that diagnoses are particularly valid constructs, but I work within a system that I also want my clients to be eligible for care. So I'm put in a position where I then have to give the diagnosis to make them eligible, even if for me...
Your incentive.
Yes, exactly. So yeah.
And yeah, for the ones that even go into, right? But since, as you've also hinted at, there's like so much out there nowadays that a lot of people also just kind of can go online and can like try something out.
Yeah.
Or the whole kind of self-treatment or self-help industry is also become quite big.
Yeah.
And I just wonder like what your thoughts are on that whole thing, on becoming as a second pillar to like established therapy and what is applicable.
Look, I think there's been wonderful advantages of that. So, I mean, I think you're kind of talking about probably mental health awareness generally improving over the last decade. And social media has had a hugely positive role to play in that. Mental health disorders have traditionally been quite stigmatized. It wasn't something that people talked about. People quite often suffered in silence. And then because it wasn't talked about, people didn't really go and seek help for it. So we've had to work very hard over the last few decades to destigmatize mental health problems and distress. And like I said, social media played a very big role in that. And it's helped. We now talk much more freely about distress. I think it's stigmatized far less than it used to be in Singapore, certainly in the younger generation. And so, of course, what we see then is we do see people seeking help more for their mental health problems as well. So that's been a huge advantage, I would say. Where it's kind of intersected and maybe started to cause some problems is that quite often the language used on social media or in mental health awareness campaigns is diagnostic based. And if you're on TikTok or Instagram, you've probably scrolled past a video at some point that says 5 signs that you have ADHD, or look through this list. Do you recognize yourself? This means you might have an anxiety disorder. We're quite used to seeing stuff like that. Yes, exactly. And so, and then if we're offering people these quite simplistic frameworks for understanding their distress. And so it becomes very tempting then for individuals to kind of diagnose themselves, particularly if we link that kind of back into the system, because as mental health awareness has improved and more people are seeking help, but if we don't actually have the services to provide help, people might go along to a clinic.
Go somewhere else.
Yeah, or they go somewhere else, or there's a long wait list, or an assessment's very expensive. So they do what they can do best, which is self-diagnose. And like I said,
I've seen that also in the kind of inflammatory language, the spillovers, like constant creep, we're called is that like we're using like depressed or having OCD way too freely or liberally, which then also creates issues again.
Yes, exactly. And that I think even in that side, that feeds back into the DSM, and we see like this kind of broadening of the scope of criteria as well. So over the years, like more and more people might meet criteria for a certain disorder. But again, that's not necessarily saying that that disorder is a real construct in the world.
It's still something we made up, basically.
It's still something we made up. And
the experience, of course, is true and real, 100%. But the way we call it, that's just one thing, as we just say we are living here in Singapore when it's really just a bunch of rocks on the water.
Yeah, exactly. It's a classification system. And it's had huge use as a classification system. You know, it's been really helpful for services organizing themselves and getting funding. Like I said, it's helped people decide on eligibility for services. So there's been some good things around it. But we kind of almost talked ourselves into a point of believing our own classification system rather than understanding that is what it is, just a classification system.
Humans really good at confusing themselves, are they?
But we're certainly humans like certainty, you know, if we go back to that self-diagnosis. So, you know, it's not to say that people's problems aren't real. Absolutely. People feel very distressed, and people can have problems paying attention, and people can have problems managing their mood or have lots of negative thinking or even kind of feel suicidal. And so when these diagnostic checklists give them an answer for why they're feeling that way, it can be actually quite comforting and relieving, and it can be quite validating as well. That people are like, oh, thank goodness there's something wrong with me. It's not that I'm just going crazy, or it's not that I'm broken somehow. I have this thing called XYZ. And now I know I have this, I can go and access treatment for it. Because again, that's how the system has organized itself. So it's almost like legitimized. The only way to legitimize distress is to give it a label. If your distress doesn't have a label, then it's not real distress in some way.
In a way, yeah.
Yeah.
At the same time, you've also written quite prominently and recently on other or improvements to this whole system and process of this issue. And I still want to give you a little bit of time at the end now to also talk about that. What for you would be the most pressing issues that we could improve in therapy?
Yes. Okay. So I think one thing maybe I haven't mentioned so far is, we've talked about diagnoses being linked to different types of treatments. What we haven't talked about is are our treatments working? And they are working to some degree. And we help a lot of people get better, but they've kind of reached a ceiling. So over the last kind of 20 to 30 years, psychological treatments haven't actually got much better.
Wow.
Which if this was medical treatment, I think we'd all feel quite shocked by. So there are still actually lots of people that psychological treatments aren't helping. And so there's an increasing awareness and understanding that perhaps that's because we are basing our treatments on diagnostic frameworks rather than basing them on the individual's personal need and distress.
Yeah.
So another framework, which, we teach here at JCU, is something called process-based therapy. And that's where you individualize therapy. You can still be doing CBT, you can still be doing ACT, you can still be doing a treatment choice that is evidence-based generally, but you apply it much more individually. So you come to an understanding through the assessment process of particular processes that might not be functioning in the best way for an individual. So I've mentioned a few of these things already. So rather than symptoms, there's things like cognitive flexibility. So how easily you are able to shift your thinking, or how stuck, in contrast, you might get on certain thinking patterns. So in OCD, we know about kind of obsessive thinking, but actually obsessive thinking shows up in lots of different disorders. How we regulate our emotions, are we able to tolerate distress? Are we able to calm ourselves down when we feel very upset? Are we able to elevate our mood when we feel very low? Again, emotion regulation sits across a lot of disorders. Attentional problems, do we pay attention in a way that's helpful to us? Do we tend to pay attention to negative things in our environment which feel like a threat to us, or are we more able to notice positive things as well? And that can be within ourselves. And again, these processes show up across all the disorders. So rather than treating symptoms of individual disorders, the idea is that you treat these core common processes that show up across disorders.
Yeah. Thanks for these insights, really. Those are things we can work on and hopefully move on towards the future of this whole profession as well.
Yes.
Thanks also for sharing some of the backgrounds, more of what JCU is doing and what you are doing too, of course. People also now know a bit more that JCU is doing things itself as well in this area.
Yes.
However, we have reached the end of this episode.
Okay. All right.
Thank you so much for coming in and talking. I feel like we have to do another one at one point.
Thank you for having me. Always happy to share more.
Wonderful. Well, that's been it. Okay, bye.
Bye.